Well, continuing in the theme of sepsis and shock, we are delighted to have Dr. David Zier here to give us our next talk, which is on fluid resuscitation and volume responsiveness. So, very apropos of what we were just hearing about. Thank you so much, Dr. Zier, for joining us.
Thank you, Dr. Hibbert. As Dr. Hibbert was just alluding to, a lot of what I'm going to talk about is going to follow directly from what Dr. Schmidt was talking about. And I'll start again with a case. I'll talk a little bit about a couple of trials, but probably not in the same amount of detail as Dr. Schmidt did. Instead, what we're going to do is we're going to center this conversation around a lot of physiology. And in the bedside assessment of volume responsiveness when we decide to make decisions regarding fluid resuscitation. All right, I have no disclosures. So we'll start with the case, and this will have some features that I would imagine are pretty familiar to everybody tuning in right now. So I want you to imagine that you're admitting a 65-year-old gentleman who was found down. And 8 hours after he arrived to the ED, while he's in your ICU, he's intubated on lung protective ventilation with an FiO2 of 0.4. He's on a substantial dose of vasopressors with norepinephrine at 70 mics per minute. You place a central line and you measure a CVO2 of 56%. And you measure a CVP at 14 millimeters of mercury. You place an ultrasound on his neck and subxiphoid, and you note, without perhaps doing any provocative measures, that he just has a large IJ and his IVC is also quite large. And he's oliguric with a creatinine far above his baseline. So incumbent on you is the decision to give fluids or not. And clearly, we just learned a lot from Dr. Schmidt, so that might inform some of the decisions that you make here. But I would ask you, do we say no? His CVP is, greater than what Rivers and colleagues suggested was, an excessive CVP of greater than 12. Perhaps yes, he's on high-dose pressors, and he deserves a volume challenge. But then on the other hand, his CVO2 was low. His vessels looked plethoric. Or maybe you say, yes, he's oliguric, and perhaps we can improve end organ perfusion by giving excess fluid. Clearly, there's a lot of room for equivocation here. And what I want to do in the following slides is talk through an approach to thinking about this question. And the way that we'll focus this conversation is the 4 points here. So the hazards of volume administration, which we've talked about a little bit already, what defines volume responsiveness, what an adequate challenge is, and then how we can make some predictions about how a patient will respond to fluid. So this is a study that Dr. Schmidt mentioned, but I think it's helpful to look at these survival curves. So this was a study, reanalysis of the VAST trial, and this was Boyd and colleagues. And they analyzed CVP and total fluid body balance. And patients overwhelmingly had a significant positive fluid balance. This was 4 liters at 12 hours and 11 liters on average by day 4. And plotted here is ICU mortality as a function of the quartile of positive body balance, controlling for age and pressor dose and severity based on Apache 2 score. Clearly, patients received a lot of fluid. And what's notable is that the more fluid that they received, the more likely they were not to survive. And what's notable, the first quartile here by 12 hours, their body balance positive about 700 milliliters and then 1.5 liters by day 4. In quartile 4, it's about 8 liters by hour 12 and about 20 liters by day 4. These data are from a retrospective observational cohort study in the Netherlands, again suggesting that a higher fluid balance in the days after septic shock reversal is associated with increased mortality. Again, reflecting that the more fluid that we give while controlling for illness severity is associated with harm. And when we think about some of the most common diseases or pathologies that we address in the ICU, acute lung injury is towards the top, and the potential for harm from excess fluid administration is accentuated in the setting of acute lung injury, as demonstrated by the FACT trial. And here, a conservative fluid strategy was associated with improved outcome, chiefly vent liberation. Notably, these are patients who were not in shock. But when a conservative fluid strategy or when patients were randomized to a conservative fluid strategy, they came off the vent about 3 days earlier than patients in a liberal fluid strategy. And there was also a trend towards improved mortality. And notably, after 7 days, the patients in the conservative group were roughly body balance even, while the patients in the liberal fluid group were up about 7 liters compared to when they were admitted. So there's plenty of data to establish that there are hazards associated with excess fluid administration in the ICU. But what defines volume responsiveness? Now, to answer that question, one thing we can do is examine a basic model of pressure across our systemic vasculature. Ohm's law governs flow through electrical circuits and posits that the flow through a circuit is directly proportional to the potential difference between the 2 points, and inversely proportional to the resistance in the circuit. Now, this equation can be rearranged such that the potential difference, V, equals flow times resistance, I times R. And this model can be translated to our systemic vasculature, where V becomes mean arterial pressure minus right atrial pressure. The flow is cardiac output, and the resistance is systemic vascular resistance, or SVR. Cardiac output is in turn determined by stroke volume and heart rate. And stroke volume is determined by the end diastolic volume minus the end systolic volume. These are then the determinants of blood pressure: end diastolic volume, end systolic volume, heart rate, and systemic vascular resistance. Now, every model is in some way a lie, and we're not going to talk about secondary effects on SVR and things like that. We're going to focus primarily on the effect of fluid on end diastolic volume and how, by increasing that or modulating that, we can augment stroke volume and thereby increase cardiac output and bring up blood pressure. I suspect that everybody listening at some point has thought about the Frank-Starling curve. Now, Frank and Starling originally described the relationship between end diastolic volume on the x-axis and stroke volume on the y-axis. And we use this relationship to plot the cardiac output curve to understand cardiac contractility and volume responsiveness. And thus, preload is also on the x-axis and cardiac output is on the y-axis. This curve essentially represents the ability of the heart to change contractile force in response to changes in preload. And said differently, when you increase end diastolic volume, if the heart maintains the same end systolic volume, then stroke volume will increase. And that scenario corresponds to the ascending limb of the curve. However, if you increase end diastolic volume and end systolic volume also increases, stroke volume will not change. And this represents the asymptotic or the flat part of the curve. Thus, this curve represents all the possible cardiac output values for a particular set of conditions. And the most important features of the Frank-Starling curve for the purpose of our conversation today is that the slope of the curve is nonlinear and is proportional to inotropy or contractility that is not constant at all volumes and pressures. Now, on the same axes, we can plot the venous return curve. Similar to Frank-Starling curve, the venous return curve represents all the possible values of venous return across a range of right atrial pressure, or CVP, which we typically measure in the ICU. Now, blood flows down the gradient from higher pressure in the veins and venules to an area of lower pressure in the right atrium. Thus, as right atrial pressure decreases or moves to the left, venous return increases until it reaches a plateau. Now, this plateau occurs at the point at which the pressure outside of the vessels is equal to the right atrial pressure, creating a equal pressure point and vascular collapsibility. Now you can see that as CVP or right atrial pressure increases, venous return falls. And so while we very often think of the CVP as the filling pressure of the right heart, it's actually the back pressure against right atrial filling. Venous return is mean systemic pressure. So the pressure, the average pressure in our veins, minus right atrial pressure divided by venous resistance. Now, mean systemic pressure is the mean pressure in the circuit, measured in the absence of flow, which obviously is not typically a goal for us in the ICU. It's determined by the stressed blood volume and venous capacitance. So as mean systemic pressure is greater than right atrial pressure, there is a pressure gradient and venous return is accomplished. When CVP is equal to mean systemic pressure, flow is zero, or venous return is zero. And where these curves intersect, or where venous return is equivalent to cardiac output, that's the actual operating point or the equilibrium point for your patient. So how does looking at this curve help us with our basic question? What defines volume responsiveness? Mean systemic pressure is determined physiologically by the volume in the venous system and by venous compliance. And adding volume to the system with fluids can therefore increase mean systemic pressure. And a successful fluid challenge therefore shifts the venous return curve to the right. You can see that the slope also will change just very slightly, and that's because the fluid bolus will also increase the volume in the vessels, increase the radius, and venous resistance will, as a consequence, also slightly decrease. Now, increasing or shifting the venous return curve to the right, assuming no change in cardiac conditions, can result in an increase in cardiac output. So in other words, this patient is volume responsive. Giving fluids increased cardiac output and should improve blood pressure, and as our goal would be in the ICU, improve end organ perfusion. However, a shift of the venous return curve to the right does not necessarily guarantee an increase in cardiac output. For the same initial parameters of cardiac output and CVP, you might have a patient with a very different morphology of their Frank-Starling curve. And in the patient for whom the current Frank-Starling curve is demonstrated, increasing mean systemic pressure with fluids and shifting the venous return curve will result in essentially no change in cardiac output. So that allows us to kind of arrive at a definition. So while we very often will define fluid responsiveness as an improvement in blood pressure or pressure requirement after giving a bolus, we can be a little more specific physiologically, such that volume responsiveness is an increase in cardiac output in response to an increase in mean systemic pressure. Essentially telling us that when we're looking at that patient, that they are on the ascending limb of their Frank-Starling curve. So what is an adequate volume challenge? As we just got done saying, an adequate challenge must shift the mean systemic pressure and therefore the venous return curve. Remember, our definition of volume responsiveness is an increase in cardiac output as a consequence of an increase in mean systemic pressure. Now, if 4 liters of fluid and blood are given to somebody who is hemorrhaging or is profoundly volume depleted, the mean systemic pressure may not increase at all. This is therefore an inadequate volume challenge. Conversely, a patient in cardiogenic shock with significant peripheral vasoconstriction might have a significant shift in the mean systemic pressure with just a very small volume of fluids. Think 250 or 500 milliliters. So again, here is our response to fluids. Now, if mean systemic pressure does not increase, there is no way to evaluate fluid responsiveness. Oops, sorry. Remember, we are defining fluid responsiveness as an increase in cardiac output in response to an increase in mean systemic pressure. Now, I think it's pretty common among house staff to, on rounds, propose giving a fluid bolus. And if blood pressure has not improved, I think the conclusion is very often that the patient is not volume responsive. When in fact, if we've not observed a change in the CVP, it's impossible to ascertain whether or not that patient is volume responsive. In a patient with cardiogenic shock and peripheral vasoconstriction, the slopes of the venous return curve and the Frank-Starling curve will be very different. This results in a lower cardiac output at the same or higher CVP. Additionally, their venous return system volume is likely replete and vasoconstricted, leading to a higher mean systemic pressure. So even a small volume challenge, again, 250 or 500 milliliters, can result in a shift in the mean systemic pressure and therefore the venous return curve. And in this patient depicted here, you can see that not only will a small volume challenge be required, but also they are not volume responsive, as the shift from the rightward shift of their venous return curve does not accomplish an increase or a meaningful increase in cardiac output. Now, on the other hand, in a patient with normal or augmented cardiac function and very low venous resistance, they might have a curve that looks a little something like this. And in this case, low SVR and volume depletion may necessitate a much larger volume challenge to significantly increase that mean systemic pressure, which again, the proxy that we're going to be measuring is the CVP. So how do we know when we give enough fluid? Although we're talking about the increase in mean systemic pressure, you can see here that in both cases, the measured CVP will also increase when the venous return curve shifts to the right. The extent to which that CVP changes is going to be very helpful for us in terms of ascertaining where they are in that Frank-Starling curve. So physiologically speaking, an adequate volume challenge increases the mean systemic pressure. And in the case of volume responsiveness, where the slope of the Frank-Starling curve is steep, volume expansion will increase the mean systemic pressure more than it increases the right atrial pressure. Thus, the mean systemic pressure minus right atrial pressure gradient increases on that ascending limb. In the case of volume unresponsiveness, volume expansion increases the mean systemic pressure and right atrial pressure to roughly the same degree, so that pressure gradient is not substantially increased. And I think for our purposes, when evaluating a patient in the ICU, I think a lot of us take a page out of Sheldon Magder's book, in that a change in the CVP of approximately 2 millimeters of mercury is what's deemed to be an adequate or more of a signal to noise than to indicate that the volume that we've given is adequate to increase CVP. So we'll move on to the last component of the talk, which I think is one of the ones where we spend probably most of our time at the bedside. And that's going to be determining how we can predict a response to fluid, to determine the patient who, determine whether or not a patient is going to be volume responsive. Now, the Society for Critical Care Medicine has gone so far as to say that heart rate, CVP, and systolic blood pressure, static measures, are alone poor indicators of fluid status. Now, Dr. Schmidt already talked a little bit about the Rivers protocol, but I think it's worth just walking, 20 years back and just kind of getting to where we are now in terms of our current understanding of CVP and perhaps providing a bit of justification for our use or non-use of the static or absolute measure of CVP when it comes to our decision-making around fluid resuscitation. So obviously CVP is going to be readily available for anybody who has a central line placed. And in the back of our minds, I think a lot of us, or I think with many, would regard a CVP in the range of 8 to 12 as being our target range. And if we look back on the original Rivers protocol, patients with a CVP less than 8 were resuscitated with colloid or crystalloid. If that CVP goal of 8 to 12 was achieved and they were still hypotensive, they were started on vasopressors, at which point, if they were still hypotensive and their SCVO2 was low, they were transfused or initiated on inotropes if their hematocrit was greater than 30% and their SCVO2 was still low. And this was initially exciting because this early goal-directed approach produced a significant, about 16% improvement in overall mortality for the group that was randomized to early goal-directed therapy. And we see that at early time points, whereas both groups started with CVP that was not significantly different, around 5 to 6. The group that received early goal-directed therapy ended up with a CVP around 14 compared to 12 for the standard group. So it seemed like whatever they were doing was accomplishing the goal, and there was a mortality benefit. Now, fast forward to, 2014, 2015, and we got the results from 3 much, much larger trials. Now, Rivers was around 260 patients, and there were 3 subsequent trials, Process, Promise, and Arise, that had very similar structures and attempted to repeat what Rivers and colleagues demonstrated. Now, without going into all the details of the trials, what we see is that in the post-Rivers era, and there's perhaps a longer conversation to be had about how maybe some standard kind of operating procedures changed in the post-Rivers era. But regardless, randomizing patients to personalized kind of early goal-directed therapy did not change really in any way meaningful clinical outcomes, most notably as demonstrated here, mortality. And when we pool all the data from Process, Promise, and Arise, we see overlapping Kaplan-Meier curves. Now, what I think from the discussion of this meta-analysis, there's this line: even though a policy that mandates routine measurement of CVP and CVO2 in all patients with sepsis did not improve outcomes, clinical judgment should always be applied. And I think that's where our current conversation regarding fluid resuscitation and volume responsiveness is so important. There's really not a one size fits all approach to fluid resuscitation, but by having a unique understanding of the physiology of the patient in front of us, we can certainly, I believe, change their trajectory. And I don't think there's any trial that to this day captures that patient level or personalized approach to volume resuscitation. I'm going to kind of blast right through this slide. This is the Clovers trial. And this, Dr. Schmidt talked about it in even more detail than I had intended to. But the failure of protocolized resuscitation, especially protocols that rely on measures such as CVP, kind of provided the foundation for the Clovers trial. And in this trial, patients were randomized to a restrictive or liberal fluid plan, or a early pressors versus early fluids. And in spite of achieving the intervention goals, there were no differences in any meaningful clinical outcomes, principally mortality. Just about 5 years after the initial Rivers trial, there was a nice prospective ICU trial that was largely in response to the Rivers trial to evaluate whether static CVP measurements are a useful cutoff to define volume responsiveness. Now, these were 150, or it was a little fewer than 150 patients, but across those patients, there were 150 volume challenges that were administered. Responders to volume were those who were deemed or who had a cardiac index that increased by at least 15%. So all these patients had a PA line. And prior to the volume challenge, wedge pressure and CVP were identical between responders, again, those who once given fluids had an increase in their cardiac index, and non-responders, those who did not have an increase in their cardiac index in response to fluids. Now, unfortunately, the ability of CVP or wedge pressure to determine or predict that response to volume was essentially like flipping a coin, quite poor. And the poor predictive power of CVP is easily seen in this graph, which shows that responders are on the left. So that's the group that had an increase in their cardiac index in response to fluids, and non-responders on the right. And then using a cutoff of 8 for CVP, you can see that there would be a number of false negatives. In other words, patients, the cutoff would suggest should not respond to fluid, but actually do. And that's the group that's circled here. And similarly, there would be a lot of false positives, patients that CVP would predict should respond to fluids, but in fact did not. Now, CVP was half of this observational trial. Wedge pressure was the other half. And we see that this measure at around, if we set the threshold at 12 millimeters of mercury, also performs quite poorly. So these static measures, turning back to this statement, are inadequate for the prediction of fluid status or volume responsiveness. Passive leg raise has been described as a way to assess the effect of change in mean systemic pressure without giving fluids. And again, this is a dynamic maneuver. This is not static. And what I'm demonstrating here is kind of a consensus way of performing this passive maneuver, emphasis on the word passive, because anything that we do that will agitate or change other variables other than simply the patient position can certainly affect SVR, can cause agitation, increase heart rate, and can also kind of confound our measurement. It's estimated that there's a transfer of around 250 to maybe 300 milliliters of blood when performing this maneuver. And you'll see in the far left diagram, the patient should ideally start in the semi-recumbent position and not supine. And then this should mobilize venous blood from the splanchnic compartment in addition to the legs, magnifying the increasing effects of leg elevation. I would say in practice, we're most frequently assessing blood pressure, but most of the trials that assess the efficacy of passive leg raise have looked at some more direct measure of stroke volume or cardiac output. But this tends to be a very good way of predicting a response to fluid resuscitation. And that statement is really borne out when we compare the response to a rapid fluid bolus compared to the same effects from passive straight leg raise. So on the left, this is just a dot plot reflecting the change in stroke volume for several patients in response to fluid, and then what they saw in terms of the increase with passive straight leg raise. And then on the right, that's the aortic blood flow, so another surrogate for an increase in stroke volume or cardiac output. And it turns out that the passive straight leg raise is a very good test for predicting response to fluid resuscitation. So a sensitivity and specificity of around 90%. And there are several pros to this. It's reversible. So if you have significant concerns about giving a patient fluid, especially if you think that they might be on the flat part of their Frank-Starling curve, this is a great maneuver. It's easy to perform. And in comparison to pulse pressure variation, which I'll talk about next, there's really no significant consideration that you need to make regarding the heart rhythm. There are a few cons, it's possible that by performing this maneuver, that 250 to 300 milliliters is insufficient to significantly increase mean systemic pressure or CVP, thinking back to the physiology that we were just discussing. And very often we'll be looking at radial artery pressures, and although those are readily available, they might not capture that increase in cardiac output that's seen. And then there might be some specific situations in which case this is an inappropriate maneuver to perform, especially if somebody has a binder on or something like that, and that could blunt the increase in venous return. Now, pulse pressure variation, I think, is another sign of potential volume responsiveness that is readily available to us in the ICU. And the physiology here reflects changes in intrathoracic pressure throughout the respiratory cycle and how those changes are then exerted on the filling of the heart. And the diagram here, I'm not going to go into all the detail, but the dotted line reflects the delivery of a passive positive pressure breath. And what we see is that that increase in intrathoracic pressure associated with that breath is going to drop RV preload. And then out of phase with that will be a reduction in ultimately the LV stroke volume. And typically it's going to be a couple of cardiac cycles before that's observed. There's also going to be an early accentuation in pulse pressure, and that's because that increase in intrathoracic pressure is going to reduce LV afterload proportional with that delivery or that increase in intrathoracic pressure. So that will accentuate the early pulse pressure, and then again, a couple of beats out of phase, we'll see a reduction. And the degree to which pulse pressure changes will depend on the amount of volume in the system. And when operating on the steep part of the Frank-Starling curve, an increase in cardiac preload from A to B results in an increase in stroke volume. And when on the plateau, there will be no response. And again, delivery of a passive breath by the ventilator decreases RV preload because of decreased venous return and increased RV afterload as a consequence of the inspiratory increase in transpulmonary pressure. And RV stroke volume decreases at the end of insufflation. And then inspiratory decrease in RV stroke volume results in a decrease in LV filling by a lag of, again, 2 to 4 heartbeats, which typically will occur during exhalation, depending on the IDE or the respiratory rate. The data that reflect pulse pressure variation very often measure it or have measured it as the maximum pulse pressure minus the minimum pulse pressure divided by the average of those values times 100. The only absolute requirement here is that the patient be in sinus rhythm. Obviously, if they're in atrial fibrillation or another tachyarrhythmia, only the conducted beats will determine the pulse pressure. So it's going to be very challenging to identify how volume is contributing to that. Abnormal chest wall compliance can also confound these readings. And the data that support this measure are all collected in patients who are mechanically ventilated. So you can imagine that patients who are spontaneously breathing can have large excursions or very, very small excursions in their intrathoracic pressure, depending on their breathing pattern. And that change in pressure is ultimately what produces the variation in pulse pressure. So if somebody is doing very quiet breathing, or if they're taking massive tidal volumes very quickly, you can imagine that that will be reflected in the pulse pressure variation, and again, can confound your interpretation. So this is another study that Dr. Schmidt referred to, but I'll bring it up again here. And this just demonstrates, again, that static measures, so right atrial pressure and pulmonary artery occlusion pressure or wedge pressure, are very poor predictors of volume responsiveness, but pulse pressure variation or even change in systolic blood pressure, which is the delta SP here, are quite good. And this was just a small prospective study, 40 patients who were intubated, sedated, receiving tidal volumes that are higher than we typically would use, 8 to 12 mils per kilogram of ideal body weight. And pulse pressure variation was used to predict response to volume. And the responders, again, were those who had an increase in cardiac index of at least 15%. And looking at this receiver operating curve, pulse pressure variation of 13% was, pretty good at discriminating between responders and non-responders. So to summarize, what's great about this is anybody with an A line in sinus rhythm is going to be, a good candidate to have this measured. But there are some really important caveats and opportunities for false positives or false negatives. And I've talked about those, but those are summarized in the table here on the right. So those spontaneously breathing, again, large tidal volumes or rapid breathing, you can see false positive cardiac arrhythmias. That intermittently conducted beat might be a larger volume, and you can see more pulse pressure variation there. And I think what's also important to point out is that low tidal volumes or poor lung compliance for the patient on low tidal volume ventilation with ARDS, those are opportunities for false negatives because the volume delivered in the excursion in intrathoracic pressure is going to be quite small. IVC distensibility is one that I think a lot of us, really like to measure because we get to pull out a, fun toy and, look at the subxiphoid and, gather around and look at the IVC. And it is in some cases a reasonable measure, but it is susceptible to a lot of the same caveats as pulse pressure variation. The way that this has been measured in the literature is the maximum dimension of the IVC minus the minimum divided by the minimum times 100. And in patients who, I'm going to go a little bit quick here, but in patients who are intubated, sedated, on mechanical ventilation, pulse pressure variation, or I'm sorry, IVC dispensability is, a reasonable predictor of volume responsiveness with a sensitivity and specificity of around 90% when 18% in terms of the IVC distensibility is regarded. Now, what's important is that this is a meta-analysis of a few studies of IVC distensibility. When patients are mechanically ventilated, this is a reasonable test. For those patients who are spontaneously breathing, the sensitivity is significantly less. So a lot of the same caveats for prediction of volume responsiveness that apply to pulse pressure variation also apply to IVC distensibility. So in the final moments here, we'll return to our case and just remind you that this is a 65-year-old gentleman on low tidal volume ventilation, lots of pressors. CVO2 is low, CVP is perhaps on the higher end. And we talked through a couple of options, but I would argue that we perhaps do not have adequate information. And in this real case, significant pulse pressure variability was observed. He received a liter of fluid, but his CVP did not change. So additional fluid was administered, his CVP increased, pressors melted away, started to produce urine. So I'll lead you with just these summary points. Probably most importantly is the definition of volume responsiveness, and that's an increase in cardiac output in response to an increase in mean systemic pressure. So the volume administered has to be sufficient to increase CVP. Excess fluid can be harmful, and dynamic measures of volume responsiveness are far superior to static ones. Thank you.